Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you, and please mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York, 12402. For more information or to donate online, visit our website at mykcr.org. Good morning, and this is Dan Gaddis, and thank you for tuning in, sharing the morning with us. Starting out the week, 7 a.m. to 9 a.m. every weekday. And today is a Medical Monday. It's Monday, September 20th, and 52 degrees. We'll be right back after these messages.
Starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Central Hudson's mobile app has a new look. It's the place to view and pay bills with ease. Check your electric and gas usage to better manage your energy consumption to save money. And report an outage. Anytime, anywhere. Use the app to easily submit your meter reading to avoid estimated bills. Download it today from the App Store or Google Play. It's free and easy to use.
To buy your home, you became a house hunting ace, learned about loans, scoured neighborhoods, and asked the right questions. Now you're queen of your castle. If you manage that, you can get your retirement plan on track. Visiting aceyourretirement.org can help. With 401k tips and smart saving strategies, you will feel empowered to own your retirement like you own your home. Go to aceyourretirement.org. Because when it comes to clearing financial hurdles, you're an ace. Brought to you by AARP and the Ad Council.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
You're listening to KCR, Kingston Community Radio, WGHQ 920 on your AM dial, 92.5 FM, and streaming online at mykcr.org. KCR's talk radio and a call-in show. Your number is 845-331-9255. And sunshine and clouds mixed for today, high of 76. Some clouds tonight, a low of 52, down to 52. And Tuesday, mostly cloudy with a high of 74. And Tuesday night, cloudy skies early with a 50% chance of showers later in the evening, and that's a low of 62. The same thing on Wednesday morning, cloudy with showers, a 50% chance of showers throughout the day, and a high of 78. And Wednesday night, considerable cloudiness with a 60% chance of showers during the night on Wednesday. So Wednesday looks like a little bit of a rainy day. Let's get to the on-air studio with Dr. Eric Stamberg. Good morning.
All right, good morning. Welcome to this morning's show. I'll be here until 9 a.m. to answer any medical questions you may have or also respond to any comments that you might have. Phone number is, I've gotten so much better remembering this phone number, 331-9255. Right? I had to clear some things out of my brain to make room for that. It must be a medication or two, and now I no longer remember the dosage of, but such it is in the world of medicine. Robin will be joining us. I did have a guest. There was a schedule snafu. I got to talk to my producer.
Okay. All right.
I got to talk to my
Have
producer.
Your people
of the
call
show.
their people.
That's right. These agents are so unreliable. All right, so we're going to just talk about general topics about medicine. I always we have some themes about this show. One of which is just general prevention. I'm a primary care physician, a family practitioner. Prevention and what is called wellness is a big portion of what I do, what we try to do. I always kind of maybe get a little defensive, but I sometimes hear that criticism levied towards medicine, that we just care about illness, and I always feel that is far from the truth, that we care very much about wellness and prevention. and being that immunizations are in the news with the COVID vaccine, the booster. Some announcements kind of coming on Friday to kind of clarify what's going on with that. And also, we have flu season, which is probably from maybe December till March. And then we have flu shot season, which is upon us right now. So before I spend so much time talking about COVID, I would talk about the flu and how important it was to get appropriately vaccinated against it. So I also thought it would just be a good opportunity to just talk about immunization in general and other immunizations that someone may want to consider that they may be eligible for. The whole realm of pediatrics is kind of a different topic unto itself. I'm not so sure we'll focus on that. I think we'll probably focus more on immunizations for the adult population. When Robin and I were students, Robin and I always say we're children of the 80s, aren't we?
Yep.
70s and 80s. The vaccines that we had were the MMR, the polio, and the DPT. All right, so that was kind of our cocktail, and then in the 90s, that kind of exploded. And maybe late 80s, when it began, but other things are now part of the pediatric realm.
Was there a controversy
about what?
At that time?
No, not really. No, I think that these illnesses were pretty fresh in the memory of communities. So vaccinations were really kind of welcome. I mean, the polio, people are terrified of polio. And that was a huge success story of modern medicine. The development of the Salk injectable vaccine in the late 50s, and then the Sabin oral vaccine in the early 60s.
I was just talking to a family yesterday. Their family hails from New York City, and they had a place up here, and they would come up in the summer. But they moved up here permanently because of polio. They were so afraid for their children that that's how they
spurred them to leave the city
exactly.
altogether.
That's how their family ended up here. Yeah,
I did that. If you're closer together, things are more likely to be transmitted.
Yep.
So there's an example of the impact that polio had on lives of families in the 30s, 40s, 50s. I don't know how what they would call a polio epidemic. I do think there was a surge in the 40s and 50s, and. All right, so just to make that a little bit germane to the conversation now, because I do want to focus more on adult immunizations. The idea, though, that we're preventing something from happening, and it's an amazing success story of modern medicine. The Edward Jenner, or maybe it's Janner, scientist from the 1700s, basically developed a cowpox vaccine. Took serum of cows that had cowpox and injected into cows that did not have cowpox, and guess what? The cows that did not have cowpox, after they were injected, did not get cowpox, and that led to the injection, development of a vaccine for humans, a very similar virus called smallpox, and it was so successful, it's going as far back as the 1700s, that George Washington actually mandated it for his troops. There's so many troops were lost to illness those days, and including, and they also kind of had to live at close quarters, not always with the best nutrition, or protection.
Sanitary conditions.
So, it's an amazing story. Edward Jenner.
Amazing. Yeah, amazing.
Who's the host of Jeopardy
That's
now?
Science, right? Science. Have you heard of this?
Science. So it really, you basically, whenever you're exposed to something to varying degrees, the body will respond and make antibodies. And those antibodies will vary as to how long they kind of live in you, the level that needs to be kept flowing around in you to keep, the prevention of getting an illness. So the idea of immunizations in general is you're just taking whatever the infectious agent is. It could be a virus such as polio, or it could be a bacteria such as like tetanus is a bacteria, and you basically take part of that infection and you deactivate it so it doesn't cause the infection, and then give it to the individual who then develops their own antibodies and then can
Fight it.
you never get it basically, or it can be very mitigating, and that is an important concept of immunizations, that they don't always prevent, but they do mitigate. They do make a infection more mild, and that's sort of what we're seeing with COVID. We are seeing that with COVID. The great majority of people who are very ill with the Delta variant have not been vaccinated, around 90 to 95% of the hospitalized patients. So there are 5 to 10% of patients who, yes, they got the Delta variant, and even though they were vaccinated, they got sick enough to have to be admitted and in some cases even fatal. But the great majority, 90% or so, are people who have not been vaccinated.
So have you yourself, or do you know anyone who's ever received allergy shots, allergy injections? I mean, this concept is exactly the same.
It's actually kind of the opposite. It's interesting, okay? So in the immunization world, you're giving me kind of an inactivated part of an infection, like a virus, part of the proteins of the virus. You're giving it to me, and then my body will make antibodies, so if I'm ever exposed to that virus, I will then not get the virus. What the allergy shots are doing is people, the immune system's just so complicated. People with allergic reactions have too many antibodies floating around. For example, people with bee sting allergy. You're not born with bee sting allergy. You live, you maybe get stung once. Your body makes antibodies to this bee sting. Maybe it makes a tremendous amount, maybe it makes a little amount, but maybe as you're growing up, maybe you get stung a second, a third time. At that point, the body has now made so many antibodies that if you're exposed yet one more time, it will pounce and cause what's called anaphylaxis. So what they're doing in an allergist office, giving a little bit of the bee sting, so to speak. I'm just giving an example. Let's think like something like hay fever, or ragweed or something. A little bit of the ragweed to just kind of get the body to use up the antibodies, so it doesn't have the allergic reaction. So in one case you want to make the antibodies, in the other case you want to use up the antibodies. That's complicated. Interesting too. Right?
Yeah. Well, isn't the hyperimmune response, like an incredible immune response, wasn't that the problem with COVID?
That's an inflammatory response, a little bit different than an immune response, a little bit of semantics too. But when we were trying to figure out the early days of why people were kind of getting COVID and being so overwhelmingly ill, there was, I don't know if this is kind of it's kind of like two subsets. There's kind of like older people who just kind of had weaker immune systems and they just couldn't handle the infection. Maybe they got a secondary infection and then there were some cases of people that had such an overwhelming inflammatory response, what was called the cytokine storm, that the lungs were filling them with white blood cells. That was part of the logic behind hydroxychloroquine. Hydroxychloroquine has a immune component that will diminish the immune response. That's why it's used in diseases like lupus, for example, and why it's extremely valuable in treating a disease like lupus. It didn't work with COVID. So it really, as a treatment, once the politics was separated, there were some very good studies that really compared the use of hydroxychloroquine to those who did not have it, and they didn't find any benefit, and in some cases even bigger concern of detrimental effects.
Gotcha.
All right. So back to immunization. So we kind of explained the basic science behind it. You're giving somebody a little bit of something that won't cause the illness, but will cause an immune response. So if the individual's ever exposed to it, they will not get the illness.
Right. So adult vaccines.
Adult vaccines. I wanted to clarify some issues regarding the flu vaccine and the COVID, pneumococcal vaccines, commonly called pneumonia shots. as well. And then some other things like the pertussis and tetanus booster. There are some adults who should have hepatitis vaccines.
Right now, since everyone was going back to college, there was a lot of kids coming in, college-age kids coming in for the meningitis vaccine as well.
Right. There's two meningitis shots, A and B. The meningitis A vaccine is a required vaccine for attendance at New York public schools. The first dose is given at 7th grade or so, and there's a required second dose that's required upon entry into 12th grade, which usually leads to a scurry. When these kids are about to enter 12th grade. In many cases, they haven't really been seen in a year or two because they're kind of getting to that point where they're just not followed as closely. By the way, I always think it's a good idea to go say hello to your doctor once a year, which means have a basic exam and make sure everything's okay, even though you might feel okay. What's the big, have your blood pressure checked, your weight checked, other interventions. And here's a good example of kind of like reviewing immunization history so you don't have that last minute. Is it a scurry?
Rush,
panic. So then there's also the Meningitis B vaccine, which is not required, and it's obviously a different strain of the meningitis, of the bacteria that causes this type of meningitis, which is called meningococcal illness. And it's generally for kids like maybe going to college. Okay, so it's a good vaccine. It's not required. It's if you look at this nation of 330 million people, the amount of serious cases caused by this meningococcal B bacteria. This is a bacteria. It's pretty small, 50 to 100 maybe on an annual basis of serious cases and including fatalities, but when it's bad, it's bad. And that's the logic behind the vaccine. So, my kids, were back. Well, I think my older kids, it was really, it's so much has changed over the past 5-10 years or so, but Sam, who's in college right now, he's had the meningitis B vaccine. So anyway, but that's not a required one usually for colleges. And colleges in general have kind of, not until recently really didn't commit to requiring vaccines a lot of times. They allowed a lot of exemptions. And before COVID, you and I were talking a lot about things like the measles outbreak. Remember that?
Mm-hmm.
And that was kind of linked to allowing enough people who were not vaccinated into a closed-knit community like a college community, which is enough to allow it to be transmitted.
We have a lot of people coming to the office that have that need the Tdap shot because their children are having children.
Yes, that's what I wanted to bring up.
Is that a new thing as far as newborns? Having unvaccinated people around the newborns?
Yeah. The key is the P of the Tdap, which is pertussis. As a doctor who went to medical school in the 90s and has been practicing ever since, a lot of these infectious diseases I've never really seen, and I probably won't see. Probably will never see, and I'm glad, and I hope I never see a case of tetanus. Probably will never see diphtheria. Probably will never see polio. I have many patients who had polio when they were younger. I might see a case of measles or mumps. Anyway, but whooping cough, which is caused by a bacteria called Bordetella pertussis, is in the community. It's out there, and it's a fairly common infection. It's not the easiest diagnosis to make. It's usually kind of a persistent respiratory symptom. Infection where a cough is a predominant symptom. And at some point, we kind of usually say maybe we should, maybe this is whooping cough. Let's run some testing. There's some new development of office-based tools that will make this an easier diagnosis. But anyway, pertussis can be catastrophic to newborns. Now, typically, the vaccines for a newborn against pertussis will start at 2 months. 2, 4 months, 6 months, but really it could take up to around a year until there's adequate immunization. So one of the preventative measures that's been implemented over the past few years is to encourage people who are going to be around a newborn to be appropriately vaccinated against whooping cough. Another thing that happens is as people age, their natural immunity to whooping cough will wane. So you and I were vaccinated when we were younger, because we're young enough to be part of the vaccinated cohort. But as time goes on, we may no longer be immune to pertussis. And in adults, it's a fairly innocuous infection. But in kids and younger adults, it can be catastrophic. And likewise, people who are maybe had pertussis when they were younger, they also may still have antibody levels that have drifted down so that they could therefore get the infection and then transmit the infection. So it is recommended that if you're going to be in a position of having a lot of exposure to a newborn and young children, that you should get a booster for the whooping cough. This is called the Tdap. It comes along with a tetanus booster, and then the D is diphtheria. And these are just generally done together. It is even felt that the diphtheria component makes the immune response even more potent. So I think that OBGYNs and pediatricians have done a good job, and other healthcare providers that take care of young patients have done a good job of getting the message out. And it's not unusual for a father to contact my office, or his grandparents to contact my office and say that their daughter is pregnant and she refuses to let them be near the kid unless they get this booster. or it's not always that, divisive. Sometimes it's just simply, this was recommended and we should get it. But there's a catch. The catch is, in our healthcare system that sends mixed messages all day long, Medicare, for example, does not cover the Tdap, which I've always found particularly upsetting. Now, Medicare kind of has different purposes in a way. It provides health care to senior citizens and disabled people, fine. But it is one of the major, if not the major, healthcare system in our country. So I think it has a greater role of promoting general health. So I think it would behoove the people who make these decisions in Medicare to cover this vaccine, so it is not a roadblock. So the cost, and it probably is. Do you have any idea how much it costs? Because it's not the most expensive, but it's not the cheapest either. It's probably about $100, $150. I'm just pulling that out of the air. Mm-hmm. It's another whole topic in medicine is that we have no idea how much things cost. But I think Medicare should cover it. I think this is ridiculous. This is our nation here. And it's very short-sighted. Anyway, so that's where that comes from. That was one of the things I did want to bring up. So if you have not had a tetanus booster within the past 10 years and have never had a booster that includes the P, the pertussis component, you should consider getting it. Just understand that it may not be covered by your insurance, and it's just something you kind of will choose to do.
I recently had it. I had a physical, so.
Right, and your doctor, being a very good proactive preventative care doctor, recommended that you had this vaccine.
I was like, I didn't step on a nail or anything.
I know there was a bar near a restaurant near where I grew up in Central Jersey called the Rusty Nail. I'm like, yikes! That doesn't sound like a very clean place.
That's a yummy drink, actually.
Oh yeah,
it's a cocktail. They just came in, gave me the shot. I had no reaction to the shot. I didn't even have any soreness. At the site of the shot, it was a no-brainer, so to speak.
We might as well review the T portion, which is the tetanus portion.
Well, that's what the nail thing I was talking about.
Yes. Well, when people say, when should they get, when do they need a tetanus booster? The general rule is if it has been 10 years since your last one, you should have a booster. And in the setting of an injury, like a cut or a scrape, if it's been 5 years or greater, you should get a booster. So Medicare will cover a tetanus shot, but not as a preventative measure, only in the context of an appropriate injury. So if someone comes in and they have a scrape, you document, you scrape and then tetanus shot, and then they will get covered. If you just put tetanus shot, it won't get covered.
Interesting.
Yes. Mixed messages.
Business of medicine.
The ugly business of medicine.
Yes.
I want to segue over to the what's commonly called the pneumonia shot, because this is a source of a lot of confusion. So it's called Streptococcus Pneumonia. Now, when you say something like strep, or kind of like E. coli as well, you really mean like a whole family of bacteria. There's other types of strep. There's strep that causes strep throat. That's called Group A strep. There's a strep that causes neonatal infections. That's called Group B strep. There's a strep that causes pneumonia and other types of serious infection, which is called streptococcal pneumonia. Sometimes it's just called pneumococcus. It's kind of like ants. You have all these different ants, right? You got big ants, small ants, flying ants. They're still all ants, but they're all different types of ants.
I like the squash analogy.
Oh, why? What's that?
Because you got zucchini and you got yellow squash and you've got pumpkins, but they're all squash.
Right. So it's kind of like that, So pneumococcal vaccines are targeted towards a couple major strains of this bacteria, which is called pneumococcus or streptococcal pneumonia, that are most likely to cause a serious infection, such as pneumonia. It can also cause meningitis. It can also just cause blood-borne infection, which is called sepsis. And there's a list of other infections that can be caused by this. So when I offer a vaccine for this to a patient, I don't mean to convey that you will never, ever, ever potentially be diagnosed with pneumonia, because there are many, many other causes of pneumonia. That's a common response. When I say, I think I got a touch of pneumonia, and they say, well, I have the pneumonia shot. And I said, well, that's good that you had the pneumonia shot. But there's other causes. So for a long time, we had something called the Pneumabox, which is against 23 strains of this pneumonia vaccine, and it was targeted towards people 65 and older, and also people of higher risk prior to age 65. Diabetics, people with lung problems like asthmatics or people with COPD, people with heart problems like CHF. Medicare does cover this. But they cover it's very interesting. Once you get it done after age 65, it does not need to get a booster. That's also a common source of confusion. Don't I need this every year? Don't I need this every 5 years? The answer is no. You had it at age 66. You're good. You're done. Unless recommendations change, and they might. But right now, that's the recommendation. Medicare does cover this, though. Usually as one time only. There's couple sorts of confusion. People don't always remember that they had it. There has been improvement in a New York State database called NICIS, which you can check and see if someone ever had it. But I think, people change physicians. It's one reason maybe it's been lost to posterity. When we converted from paper charts to electron, to EMR, or just from one EMR system to another, the data might have gotten lost. That's and then another source of confusion these days is getting vaccines from multiple sources. Something that on one level sounds like a good idea. Let's let the pharmacies, for example, give this vaccine, but on another level can kind of lead to someone getting a vaccine that they've already had, or just confusion about whether or not they need it or not. So. But I am optimistic that will get better as a database improves. So a source of confusion, we're approaching our first break, is this other pneumonia shot that's come up recently called Prevnar. One minute break. So Prevnar has been part of the pediatric vaccination for a while now. Probably about 20 years, maybe 25 years. Whereas the first pneumococcal vaccine covered 23, the Prevnar covers another 13 strains. And sometime within the past 5 to 10 years, Medicare started to say, we came from the CDC and the Preventative Services Task Force. We recommend this vaccine for people 65 and older, kind of like what part 2 of the pneumonia shot. So we started to give it. And you're supposed to separate it by a year. I'll a year and then technically do one before the other. It got very complicated. We'll revisit this complicated subject right after the break.
Thank you, Dr. Eric Stamberg and Robin Baker. Thank you for bringing us around to the 7:30 moment here on our 7:30 break. Thanks to our hosts. And you're listening to KCR, Kingston Community Radio, on AM 920 and 92.5 FM, and streaming online at mykcr.org. And it's 52 degrees right now here in Uptown Kingston, and it's Monday, September 20th, and we'll be back right after these messages.
Starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Electrical fires can be caused by overloaded circuits or outlets, frayed wires, faulty appliances, or deficient cords. This is Central Hudson reminding you, in the event of an electrical fire, call the fire department and let them know it's an electrical fire. Never use water to put out the flames of an electrical fire, as that may cause serious shock. And use only an approved fire extinguisher. If possible to do so safely, shut off the main breaker. Your safety matters.
Everyone is talking about healthcare these days. America spends twice that of other developed countries on our healthcare system, yet our health ranks near the bottom. How can we stop spending so much and getting so little? By shifting to a system that gives more patients access to strong primary care. Primary care can help make America healthy again. To learn more about the benefits of primary care, visit www.healthisprimary.org. This message is brought to you by America's Family Physicians.
Hi, this is Eleanor Arrow from the town of Ulster, and I support Kingston Community Radio, and so should you.
You're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. 7:32 a.m. on this Monday, September 20th, and it's 52 degrees here in Uptown Kingston. We woke up with a kind of a chilly day, and sunshine and clouds will be mixed today with a high of 76. Some clouds and a low of 52 tonight. And Tuesday, mostly cloudy with a high of 74. And Tuesday night, cloudy skies early with some showers coming in later at night. It's a low of 62. And then on Wednesday, cloudy with showers, a 50% chance of showers on Wednesday, a high of 78. And Wednesday night, considerable cloudiness with occasional rain showers, a low near 55. That's a 60% chance of rain on Wednesday. And this upcoming portion of Kingston Community Radio is brought to you by Central Hudson. Now let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker. Welcome back.
All right, thank you. Welcome back to the second half hour of this morning's show. We are focusing on adult immunizations, kind of building up to a discussion about the COVID booster vaccine. If you have any comments or questions, 331-9255. I always try to throw in whether or not something is covered. I think patients should know if something's covered before they get it done. It's not always easy to figure out. There are plenty of times where I have to say to someone, I don't know. I guess we'll have to try to figure this out. Sometimes I ask the patient to do the legwork, to varying degrees, or we do it in our office. So we were talking about the second pneumonia shot, which is called the Prevnar. That Medicare was recommending it, kind of came out of recommendations from the CDC and the Preventative Services Task Force. Basically, the recommendation was taken back. Kind of said, you know what, we reviewed the data and we really don't think it's necessary. The extra strains that this vaccine provides coverage against, the Prevnar 13, are not really common enough in older patients to be an issue. So that's led to a lot of confusion. A lot of people spend we spent 5+ years telling people to get 2 pneumonia shots. We're kind of back to 1, although I don't know. I'm not so sure the message has gone out as thoroughly as it could.
Yeah.
Another vaccine worth mentioning is the Shingles Vaccine. This is an interesting. This this gives you also kind of an idea of what's going on with a vaccine. So remember, it doesn't always prevent an illness. It might mitigate an illness. And in the case of the Shingles Vaccine, it actually is trying to take something that lives in you already and keep it in check. So we almost 100% of people have been exposed to the chickenpox virus by the age of 30, maybe 35. In pre-immunization time. So, it's a little bit different now because immunization against chickenpox in the pediatric population has kind of changed how we look at this. But say you and I, when we were younger, my mother says I had a very mild case. Did you have chickenpox?
I did.
You had real chickens.
No. When I had the chickenpox, we didn't have chickens.
Okay. I'm joking, though, by the way.
But there's pictures of me I was like in a...
With chickenpox or
yeah, with chickenpox.
Okay. So you had a case?
Yeah.
All right. Dan, do you have chickenpox?
Royally. Absolutely, I do remember.
Remember how old you were?
I was out of elementary school when I had to take off school. I think I was in elementary school at the time. So first, second grade. I think second grade.
It can be more severe as you're a little bit older when you get it, and that may be because of some protection from the mother, or at least for the first year of life, which is good, by the way. The mother will give antibodies, particularly if she continues to breastfeed, to protect the baby. That's something we never really talked about, was the benefits of breastfeeding.
Yeah.
Anyway, so we get chickenpox, and it lives within you. That's why you never get it again. You only get chickenpox once in your life. But because it kind of lives in you, and it lives in nerve roots, it can reactivate. And it reactivates on a very specific pathway that will never cross the midline of the body and will always kind of be one part of your body. Maybe your thorax, maybe the side of your face, it could be an arm, a leg, and it will manifest as kind of a painful rash, kind of looks a little blistery, very similar to the way chickenpox can look. In addition to pain, the patient will have other symptoms like burning, tingling, itchiness, just kind of something. It can be very, hard for patients to get this. So you know what that condition's called?
Shingles?
Shingles. I have no idea where that name comes from. But so the idea of a shingles vaccine to kind of keep it in check. So when you're younger, you get chickenpox. Your body makes antibodies, and those level of antibodies keeps it in check throughout your whole life. But for various reasons, the level of that antibody will trickle down. One is just time and age. Sometimes the setting of some sort of event might kind of also upset it, like a major illness. But as we get older, our level of antibody against that chickenpox virus trickles down, and then the virus can then kind of pop out as a case of shingles. So in addition to being a very painful condition, it can also be disabling. It can lead to a chronic pain that's called post-shingles neuralgia. Someone could really just have pain in that area for the rest of their life. If it involves the eye, which it can, that can be very serious and usually requires the care of an ophthalmologist. What's that?
Shingles.
Oh, okay, what?
Also known as herpes zoster. Gets its name from both Latin and French words for belt or girdle.
Interesting.
Which is where it erupts. It refers to girdle-like skin eruptions on the trunk, essentially.
Wow.
Which is more common than anywhere else. Yeah.
There
we have it. It just comes from Latin and French shingle for the word girdle or belt.
Robin, that's interesting.
Just looked that up too. Yes.
And another thing you mentioned was the other word for shingles, which was herpes zoster. So herpes is a term that can upset patients if you give them the diagnosis. Cold sores is called herpes labialis. Sounds horrible, doesn't it? Cold sores or fever blisters. So herpes refers to kind of a family of viruses that includes causes of sexually transmitted herpes infection, but it also includes the chickenpox virus. So that's sort of where that comes from. So if you're diagnosed with herpes zoster or herpes labialis. It is not a sexually transmitted infection. So what the vaccine does is takes that level of immunity that's kind of trickling down and boosts it back up. This vaccine's been out for a while. It's kind of changed. For a long time, it was out of something called Zostavax. And then kind of a new improved version came out called Shingrix. And Shingrix is 2 doses, usually separated by a month. It's approved for 50 and up. For a long time, we were kind of focusing on 60 and up. Since then, we are kind of rebirthing our efforts to focus on people in their 50s as well. I have no idea, why that cutoff is drawn. It could be just because that population is at increased risk, and it really is kind of a one-time only vaccine, at least now. 10 years from now, maybe there'll be a recommendation saying you should get a booster. Who knows? This vaccine can be also complicated in how it's administered. It's covered by Part D of your Medicare plan, and a lot of Medicare plans insist that it be done at the pharmacy. So a guy like me has to send a prescription. Some Medicare plans will allow it to be performed in our office, and we keep a supply there, but it's not easy to figure out. And so when it comes up usually in the context of a wellness visit, I will say to the patient, yeah, I agree. You should have the shingles. And by the way, the patient brings it up a lot, which is great. I agree. And I think we got to check with your insurance, and unfortunately, sometimes it's not covered. So I can't quite figure this out. This is a very frustrating part of my job. This kind of, in addition to kind of like recommending something,
depends on your plan, right?
Yeah, and having to kind of like be like almost an ombuds person for the patient and their interaction with their insurance plan could be time consuming and frustrating.
Yeah.
So I don't think straight Medicare covers the shingles vaccine. I think some of the Medicare Advantage plans do, which is kind of a topic unto itself, Medicare Advantage. But this might be an advantage if they cover it.
Right. And it is confusing. One more thing that's very confusing for patients.
But it is a good vaccine, and if you're 50 or older and you have not had it yet, you should. It will prevent you from getting shingles. And if you've already had shingles, you still should get the vaccine. Because even though you're less likely to get it again, you can still get it again. I've had plenty of patients who've had shingles multiple times.
It's not fun.
No. It's a very interesting diagnosis. And
quite painful.
There is treatment. So if you develop shingles, you should seek care, because the sooner you get on the treatment, the more effective it will be. There's antiviral medications called Valtrex and Famvir and Zovirax. These are the brand names of these medications that will fight the virus and keep it in check.
Great. I wonder how the people listening feel about vaccines. How do they feel about getting them?
Yeah.
I mean, at the office, it's like a no-brainer, especially senior citizens.
Yeah.
They're like, time for my vaccine. I need it. They're just happy to get it. So it's interesting to me.
I know.
How people feel about it.
Do you have some stats on breakthrough cases where you've been, vaccinated twice and you
I can't give you a number, but I can probably try to look it up for you. But I know it's less likely. So you get chicken pox, you get that antibody. It trickles down, you get shingles, and the body will then make some more antibodies again and hopefully keep it in check. So, but it will still trickle down as time goes on and potentially break out again. So that's sort of why, if you get that vaccine, it's kind of, it's analogous to what's going on in COVID now, when I'm advising people who've had COVID to still get the vaccine. And we'll bring. I'm kind of building up to focusing on COVID a little bit. There's a method to my.
There is.
Yes, there is.
So, but the Pneumabox is one and done, but the shingles, isn't there two?
Yeah, it's interesting because the Zovirax, which was the old shingles vaccine, was just one. The new improved shingles vaccine called Shingrix requires 2 doses. Go figure. I don't know. But yeah, it's 2 doses. I've had mine. Have you had yours?
No, because I'm very young. next time. Right. And the second dose is within 2 to 6 months of the first.
Okay. I thought it was 1 to 2. See, it shows, but that's okay. Yeah, it's another good rule about vaccines. So, for example, if you get a vaccine and you're told get the second dose in 2 months, I don't know, something happens and you show up in 3 months, it's not ideal, but you just give it anyway.
It's fine.
It's fine. You just don't want it too soon because you're kind of maybe wasting it. You're giving it before the body needs it, and it doesn't make a difference. So sometimes, very briefly, sometimes Medicare does cover hepatitis vaccines, but you have to have an increased risk of hepatitis. So usually that means, if you have hepatitis C, for example, Medicare will cover vaccinations against hepatitis A and hepatitis B. But that's a subset. You have to have some diagnosis that puts you at risk. But it does get covered. It's not for the general population.
Which type of hepatitis is curable?
It's now all of them, because there's been such tremendous improvements in how we treat these infections now. So there's basically A, B, and C. There are probably more types. Sometimes if there's a D, there's an E, but mostly we're talking about A, B, and C. A is a oral vaccines. And whenever you hear stories of a hepatitis outbreak at a restaurant, for example, which is why we have a public health system of inspecting restaurants, for example. We talk about the world of public health. We're looking, make sure they maintain a certain level of hygiene so you don't get things like a hepatitis outbreak or other outbreaks. Hepatitis A can make you very sick, but it doesn't really cause chronic problems. It doesn't really cause cirrhosis or liver cancer. B and C can make you sick, usually, acutely, but a lot of times they don't, and or not that bad. So you might think, for example, you just have a virus, but down the road they can really lead to two horrible diagnoses, which is cirrhosis and liver cancer. The hepatitis B vaccine is generally sexually transmitted. It is required to be vaccinated against hepatitis B to attend public schools. I think we talked maybe last week about that. That's kind of a controversial. That was one of the things that kind of opened up the controversies in the 90s, that we were vaccinating against something that was for later in life, and we were also vaccinating against something that was not really communicable unless you had sexual contact.
Right.
Hepatitis C is bloodborne, so it's seen a lot, and people have used intravenous drugs, for example. But there's a lot of people with Hep C that don't have an obvious cause. So for a long time, we were supposed to be screening people born between 45 and 65. Recently, the screening has just been expanded to almost everybody. There is treatment. Dr. Isabel, my colleague, prescribes this, and doctors in your office, infectious disease doctors, will prescribe it too. These meds are curable. I'm trying to remember. At least Mavorette is one brand, for example. Very, very expensive. So of course, insurance companies don't sit there and go, "Oh, okay."
Right, it's a fight.
Yeah. It's you have to really kind of, and it gets a little more complicated. You have to do different subsets of the virus, which is called genotypes, to see if you have better likelihood of responding to the treatment. But these treatments have been game changers. Prior to these treatments, we used a combination of something called ribavirin and interferon, which kind of works, but interferon was a very hard to tolerate medication. It almost works by causing many symptoms similar to being sick: fever, malaise, achiness. So not only are these medications very effective, their side effect profile is negligible, especially when compared to the prior treatment we had.
Right. I mean, employees want this too.
Well, what?
Employers want to know, like, if people are vaccinated or not.
Against hepatitis?
Well, most vaccinations, I think.
Right. I think in the healthcare world, you're supposed to be, I don't know if it's required but many jobs will require it. or you have to sign some form declining it or whatever. But it's very common for someone to be starting a job, and we will have to provide dates of their hepatitis B vaccine or a titer. Titers can be useful. Titers are levels of antibodies in your blood. So a lot of times it's not that practical or easy to hunt down someone's immunization records. I had my hepatitis B vaccine as a med student. I don't know what the dates are. They're probably buried somewhere in the scanned portion of my medical record. But it's not that, it's not, it can be easy to locate. So a lot of times for patients who need something for employment, the employers will ask for an MMR, which is measles, mumps, rubella level, and varicella sometimes, which is chickenpox, and hepatitis B. I usually just say, why don't we just get a set of titers, and you can keep a nice copy, whenever you have to produce it again.
Why do employers want that TB test? That's a skin test, right? A skin test that you have. It's usually done.
It comes from public health measures. That it might be a little antiquated now, but they were quite effective at limiting the spread of TB. Generally, it's for health-related fields that you have to have a TB test.
No tuberculosis vaccine, though.
There is one, which is called the Bcg vaccine. It's used on the worldwide basis in parts of the world where tuberculosis is so endemic. It's not a particularly effective vaccine, but if you're in a country like India, for example, where there's a lot of people and there's a lot more tuberculosis, even though it's not as effective as we would like, it still is effective enough to help stem the spread of tuberculosis. In our nation, we simply don't have enough tuberculosis, which is good, to justify giving the vaccine. But there is a vaccine. It's also interesting because this vaccine called the BCG shows up in the world of urology as a treatment for bladder cancer, where a urologist will infuse the vaccine directly into the bladder, and it helps treat the cancer. I have no idea why. I don't have no idea how they figured this out. It's really amazing. But it's a standard treatment for people with bladder cancer.
Wow.
Get BCG treatments. It also makes your PPD test always positive. So, because it's a live virus, so it kind of lives within you and causes that reaction. So before we end this section, I just to briefly talk about the flu shot, because you and I talked a lot about the flu shot before there was COVID.
Yeah.
And we were in flu shot season. We were terrified a year ago that we were going to get kind of a double hit. People were going to get COVID and the flu at the same time. And for reasons we don't quite understand, the flu season was negligible. I guess the reason most likely is that the masking helped control the flu, which kind of sends them, for people kind of argue about masking. It kind of like, I don't know.
Negates that.
Yeah, kind of. But at the same time, COVID got around, which kind of, to me, implies that the COVID virus is a lot more contagious than the flu virus. So in other words, a basic masking and distancing helps stem the flu virus, but does not do such a good job at stemming the COVID virus. That means the COVID virus is more infectious. Anyway, that's observational. Observational conclusions can be helpful. That's the kind of the basis of scientific method. People observe things, form a hypothesis, then go test the hypothesis. It could also lead to kind of anecdotal conclusions and therefore, decisions. For example, someone says, I had the flu shot once and I got sick, so I never want it again. So to them, that's a connection. That's an anecdote. Or my friend got sick.
So, like what you're saying with the vaccine,
Yes.
you're saying that you technically, scientifically, you're really not injecting something into somebody that's going to make them sick.
Right. You could have basically just what's called a killed virus, which means there's no elements of live virus or bacteria in the vaccine at all. Sometimes you will have what's called a live attenuated virus, kind of it's still live, but it's mutated and won't propagate. It won't cause the illness, although it might mimic some of the symptoms when you look at side effects of the vaccine. So that's where it gets a little confusing.
That's very confusing. It's not a little confusing. Or does your immune response make you sick sometimes?
Yeah, immune response makes you very sick. That's a whole argument over treating fever, for example. Fever, in most of the time, is your body fighting the infection. So do we want to treat the fever? If someone's running 101 and they're fighting infection, do we want to bring it down to 98, or do we want to allow the body to kind of keep fighting the infection? Generally, if the fever is causing you to feel more ill, you probably should treat it. Fever itself is pretty lousy. Makes you very tired, achy.
No fun.
Right. We've all been sick. You take a little Tylenol, an hour later, you feel like $1 million.
$1 million?
In 2020, $1. Not quite $1 million, like Dr. Evil from Austin Powers. $1 million. Yes. So anyway, so the flu shot. So one thing I think maybe we are guilty in the medical world of overselling the flu shot in the sense that you're not going to get the flu. You're not going to get the flu. We've known that it doesn't always prevent the flu, but similar to the COVID vaccine, that mitigates the flu. So it's not unusual to get the virus and later that season get the flu. The flu shot is also against influenza A. Remember, there's also something called influenza B. So the flu shot won't really cover that. So a couple years ago, we had a lot of influenza B flying around. Remember we talked about that? Remember?
Yeah, there was a lot of kids that got sick, and we had a lot of fatalities.
Right. So you should still get the flu shot, even though the last season was mild. Every year can be different. The fear is still present that people can have a double hit with COVID and the flu. So we still recommend the flu shot. And now's the time. That's a very good time to get it,
All right. Clear up the distinction between the two flu shots, because I know that this becomes an issue in our office.
High dose and the regular?
Correct.
Okay. Well, there's something called the high dose, and there's something called the regular. The high dose is more potent. But it's really recommended and approved just for people 65 and older. So what does that mean? It means that, there's a business of medicine. So the makers of this virus, they, of course, want to sell as many doses as possible.
Not the makers of the virus.
Makers of the vaccine. They want to make as many doses as possible. So they go to the FDA and say, we want this to be for everyone. The FDA says, well, show us your data. And the FDA will review it and draw a conclusion that, yes, this vaccine is beneficial to people 65 and older. Therefore, it should be given. But people less than 65, it doesn't make a difference. And therefore, the regular dose is just fine. And that's kind of what it means.
It's kind of hard for a 64-year-old.
Yeah.
Who's like, hey,
what about me? Well, the cutoffs are kind of arbitrary. So the flu shot, you should treat it like any other season and get the flu shot. Most reasons that I hear for the flu shot, for not getting it, are really not valid. I had it when I was in the Korean War.
It's going to be very hard to convince someone who had a flu shot and felt like they got sick from it, to convince them otherwise. Yeah, I don't think you are.
I know, and it's a.
And what do you say? Give it another shot. Go ahead, try it again.
I try.
What if you don't get sick?
To varying degrees. You're right, though. Some people, they have minds made up, and they, a few of them learn the hard way.
Right, because then when you get the flu, ouch.
Ouch. Look, I hope we have a flu season like last season.
Yeah.
And I hope that we, at the same time, continue to see declining COVID numbers. So that brings us to, we're almost out of break. I guess we'll visit after our break. But I did review the COVID numbers in Ulster County and neighboring Columbia and Dutchess County. They're kind of level, and there might be a slight down.
Well, because they were so elevated.
There's always new numbers that come out on Monday. It'll make it a little bit difficult to do Medical Mondays sometimes because we're doing the show before the new data come out after the weekend. But there are people in the hospitals with COVID, and most of them are not vaccinated. A lot of people kind of in their 50s, sometimes like, diabetes or whatever. And I do kind of think, and maybe I don't say it, but I'm like, you really should have known better, Other people just kind of think they're healthy enough and didn't need it, which is, unfortunate. But I'm hoping that they'll use their experience to spread the word to others, which happens a lot. All right, let's go to our second break.
Okay, thank you, Dr. Eric Stamberg and Robin Baker. KCR is Kingston Community Radio, WGHQ, AM 920 and 92.5 FM. Time is now 8 o'clock a.m. this Monday, September 20th, and 54 degrees here in Uptown Kingston. And this last portion of Kingston Community Radio was brought to you by Central Hudson. And we'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5. Thanks for starting your day with Kingston Community Radio.
A lot of talk about the COVID-19 vaccines, and everyone has an opinion. So I went to somebody I already trusted, my doctor. Talk to your doctor or healthcare provider and make the decision that's right for you. Go to getvaccineanswers.org for the latest information. Brought to you by the Ad Council.
Look through your children's eyes, and you will discover the true magic of a forest.
Find a forest near you and start exploring at discovertheforest.org. Brought to you by the United States Forest Service and the Ad Council.
We are Lions. We bring hope where it's needed. We are a global force for good. Support causes that matter. Change lives. Change communities. Change the world. We can do more together than we can alone. Join in. Experience the joy of serving. Be part of the movement. Give back. Let's unite the world for good. We are Lions. You can be too. Visit weserve.org.
Hi, this is Scott Harrington from Hurley, and I support Kingston Community Radio because the people need a place to have their voice heard, and it's lost in corporate radio, so please keep listening and supporting our station.
And we're back, and thank you for being with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. Today you're going to get some sunshine and clouds mixed with a high of 76. In this Kingston and surrounding areas. Some clouds with a low of 52 tonight, and Tuesday mostly cloudy with a high of 74. And Tuesday night, a little bit of rain comes in. Cloudy skies early with showers later in the night, and a low of 62. And Wednesday, that rain continues. There's a 50% chance of rain during the day with a high of 78. And 60% chance of rain Wednesday night with considerable cloudiness, occasional rain showers, low near 65. And let's get back to the on-air studio. Oh, by the way, we've got a sponsor for this upcoming segment as well, and that is Herzog's. At Herzog's Home and Pain Center, community, family, and neighborhood all matter. Herzog's employees have been part of the Herzog's family for years, and they value personal customer service and being close to their community. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs, and discover the difference of buying local. Sales ongoing at their website, herzogs.com. Let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker. Looks like we have at least one birthday.
We do, by the way. Thank you to Herzog's for being such a wonderful place to get things.
Yeah, if you need things, you should go too. There. I know.
It really, I always find that I buy a lot of stuff at Herzog's.
I love Herzog's. It's awesome there.
Pavers, all those pavers, incredible pavers for your patios and things like that.
Really, just in the, I guess if you're coming through the front on the left, they have like a gift section, which really has a lot of fun,
unique things.
Yeah, you can grab a gift. Stuff. You have to get your cement or your new
What's he talking about?
your new Yeti, or your plumbing supplies, and then you can get a gift for somebody.
Oh, the Yeti is an interesting topic. Where'd these things come from?
Yeah, they're popular.
Talk about marketing. I mean, they're very strong. Yetis.
Yeah. Well, they ought to last a lifetime.
Yeah, if I had one, I'd lose it in about 20 seconds. All right.
Well, we have two birthdays today. They were both submitted by a wonderful woman named Diane Timolo. And Diane sent us a couple emails, and she's got two birthdays in her family today. So she's wishing a happy birthday to her niece, Andrea Silnovich. Love, Aunt Diane. And also happy birthday, September 20th, to my brother-in-law, John O'Rourke, from your favorite sister-in-law, Diane. So, John, this is your favorite sister-in-law, Diane, wishing you very happy birthday, and happy birthday from all of us here.
All right.
So it can only be one winner.
Only one winner.
Oh, please.
And you will receive a famous cow pie from Boyce Dairy Milk House, 62 O'Neill Street, Kingston, New York. Today's winner is...
John O'Rourke.
John O'Rourke.
John is a big winner. Your favorite... very favorite sister-in-law. I hope there's not another sister-in-law.
I don't know. That's all we need is feuding sister-in-laws.
Like the Tomalone family. The O'Rourkes.
Yeah,
I thought I was your favorite. No, you are.
Sister-in-laws always get along with each other. Don't worry.
Yeah. Oh, yeah.
I hate her so much. Okay. So I think it's the flu shot we mentioned. Let's talk a little bit about the COVID booster because it came up on Friday afternoon. The FDA gave their big conclusion. The president, I think, was a little premature. A couple weeks ago, he started to say boosters are out. Everyone start getting them. And he really should have waited for this decision. And I did a little research in this, and there was a doctor, part of a Brown Medical School in Rhode Island, was talking about it on CNN, and she was saying, you know what, we're even a little confused by this too. But basically, this is what they announced. If you have had the Pfizer vaccine, and you are 65 or older, and it's been at least six months since your second dose, you should get a booster. So they have not weighed in yet on the other vaccines, the Moderna or the J&J. And they also said, in addition, 65 and older, also people at increased risk. They did not define increased risk. We are waiting for conclusions, for more description regarding what that means, increased risk. So for now, if you are over 65 and you have had the Pfizer and it's been 6 months or more, you should get a booster. So now what? Again, this is all kind of being rolled out, works in process. I think you should contact wherever you got the vaccine. And hopefully they'll be able to give you some direction too. I want to encourage people to be a little patient about this. This is all kind of hot off the presses. The announcement is 3 days old at this point. So, to kind of expect everything to happen today, for example, might be a little unrealistic.
Is there a time frame? Initially, there was one thing that came out 8 months after your second shot.
I don't know what happened to that.
But
right?
Is that not true anymore? I mean, who are we turning to for this information?
The FDA.
Okay.
So right now, I would advise people to sit tight. I think it's all going to happen. I think it will be kind of rolled out the same way the vaccine was kind of rolled out.
Right. Well, if history serves itself, I mean, we were very caught up in the fact that initially the vaccine was released and it was hard to get, right? Remember?
Oh, absolutely.
People traveling all over the state trying to find it. Right.
Yeah.
And then here we were with it in abundance, and it's here, and you can get it anytime, and you can pretty much get it anywhere. Right. And even the testing now is more readily available. I know that I had a friend who just went to Walgreens and picked up a pack of 2 tests. I haven't shopped for it, so I haven't seen it myself. in CVS or Walgreens? Have you seen it?
No, I've heard about it. I have mixed feelings about that. I think widely available testing is okay, but I just always worry about testing outside of context. Why is that person being tested? Are they symptomatic? If they are they potentially being are they a candidate for treatment, for example, the antibody treatment, or are they being following appropriate advice?
So what this person who I know got the 2-pack at the 2-pack of rapid vaccine at Walgreens, they were advised to get that by their doctor, to take a rapid test to see if it was positive or not. If it is positive, they were advised to quarantine, and they were also advised to get a PCR test to be sent out so that they could determine, because sometimes the rapid tests, I know positive is positive, but sometimes if they read negative, sometimes they're maybe not correct, and the PCR is more accurate. So,
okay, I don't know if that's necessary, but I will yield to the judgment of the provider. How many women did a home pregnancy test and then went out and got a second and third one?
Is this right?
That's right. Did I do it right? So I guess the value of the PCR, now that I think about it, that we do have a very good treatment, which is the antibody treatment. And the government really broadened the range of people who are candidates for this treatment. And it's underutilized now. Some of it is just providers of the treatment having a hard time keeping up with demand, and that's kind of a different topic. But I think that, if someone's going to be a candidate for this treatment, it's probably a good idea to really have that PCR to just kind of confirm the positivity rather than the subjective, is there a line or isn't there? I guess that's part of the problem. When you have a rapid test, like a strep test or a pregnancy test, yeah, sometimes that line is, sometimes it's kind of like you're turning it in the light, you're kind of squinting, is there a line there or isn't? So I guess it's not bad practice to tell people if the rapid is positive to go ahead and get a PCR. I just worry about testing out of context. I've seen it at some urgent cares that pretty much that's all they're doing is just providing a test. Now, look, if the reason is for travel or employment, I guess that's fine. But if they're working up symptoms,
Right. Well, isn't being symptomatic totally different?
Yeah.
I mean, it's a whole different
But someone,
set.
for example, might be symptomatic and they think, all they need is to just go get a test, which is not unreasonable.
Boy, this gets really confusing for people, because what if you're symptomatic and then you have a negative test? So you don't have COVID, but you have a cold, or.
But to me, that's a better use for the PCR, because the PCR, if someone has suspicious symptoms and the rapid is negative, I think a PCR is a good idea to send it out. And advise the person to quarantine until results come back.
Yep.
People are asking a lot about antibody levels. They want to have their antibody levels checked.
So is that kind of like the titer you were talking about before?
Yes. So, and that's one thing I wanted to bring up. Basically, we know a lot about titers of things like measles and mumps and rubella and chickenpox and hepatitis B. It's established. This means you're immune. This is borderline. This means you're not immune, which means you're at risk of getting the infection. Generally, if I do titers on someone for hepatitis B, for example, and it comes back as borderline or non-immune, they need to have a booster. So one of the things that's been confusing about COVID is the idea of natural immunity. It's been said, even by some allegedly medical sources, that natural immunity is better than immunity given by a vaccine. They're just kind of wrong. Every infection is a little bit different. They're trying to extrapolate maybe natural immunity from chickenpox is better than getting immunity from the vaccine. We don't even know that to be true. I've heard that postulated many times over the years, but we don't even know if that's true. But they're really just kind of giving information that's not accurate. And I don't find much value or any value in checking antibody levels for a couple of reasons. One is if you already had the illness, you're right. You will have some antibody. And you're right that may be giving you some protection against getting COVID. The issue is it giving you enough protection against COVID? And the answer is we don't know. We know what level of measles antibody makes us say you're protected. We don't know what that cutoff is for COVID. Most tests for COVID antibody are not even really giving you a level. They're just giving you a positive or negative. So, people are really venturing into, sources of information that are unreliable. The recommendation is really quite simple. If you have had COVID, you still should get the vaccine, and that's kind of it.
Got it.
It's still recommended to do it about 3 months after you get the infection. So I get that request a lot. It's a little frustrating. Sometimes I just simply say I don't recommend it. Because my recommendation to you is going to be the same, regardless of results. I did have a patient last week. I guess it was silly in medicine, but, sometimes they just kind of ask nicely.
Is there a harm in getting the antibody? I mean, you could just...
I think there is.
No or not no?
I think there's harm because I think someone might reach the false conclusion that they're protected and not be.
Use it as a reason to not get the vaccine.
Yes.
Gotcha.
The role for the antibody is now out. What's the word? It's not no longer accurate. There was a time that we were using convalescent serum. We were taking almost like the Edward Jenner cowpox treatment. We were taking blood from people who've had COVID and giving it to people who
were sick with COVID.
Sick with it. But that got replaced by the Regeneron antibody treatment. So
monoclonal antibodies.
Monoclonal antibodies. But that is just simply is in the lab setting, taking a very specific antibody called the one, and cloning it, making multiple clones of this one antibody, rather than in the serum, it's a bunch of everything.
I read up on that. And I saw a video about this. It's amazing.
It is amazing.
It is amazing. If you have a chance, you should Google it because it's actually fun reading about it, how it works and what they did, how they do it. It's amazing. They, the scientists.
They.
Them.
Yeah,
the scientists. I mean, this is it really was incredibly interesting and amazing.
Right.
How it helps people.
The whole idea of something called a PCR, which stands for polymerase chain reaction, was kind of a technique. I remember they were raving about it when I was in medical school. Basically, you were able to take a little of a DNA sample, throw it in a container with a bunch of ingredients, shake it up, like making a rusty nail. And do you shake a rusty nail?
I think, no, stir.
What would you shake up?
Margarita.
Okay, so like making a margarita. Take a little of the patient's DNA, throw in these ingredients, shake it up, and it would replicate and make a lot more of the DNA. Therefore, you can then test it and detect it. That's kind of what a PCR stands for. It's interesting.
Very.
Yes.
Very interesting.
So I don't think the antibody, I don't think you're getting good advice. There's some proponents, I know Senator Rand Paul, who's I'm sure an excellent ophthalmologist, probably knows very little about infections, talks about natural immunity. But again, you really got to think about where you're getting your information from. Not all doctors are the same either. If you want to listen to me about eye infections, or you want to listen, or you want to listen to me about glaucoma, you want to listen to Rand Paul. Rand Paul's probably your guy. If you want to listen to
Dr. Froud
or Dr. Froud about what to do about the COVID virus, I would really recommend Dr. Froud. By the way, his book's available.
Plagued
by
Dr. John Froud. Excellent read, by the way. A lot of fun. Almost done.
What are you up to, like the 1600s?
What, do you want to read it?
Yeah.
Yeah.
He gave us a signed copy.
There's
You took it right
There's
away.
going to be a book signing. I don't know when that's going to be.
Oh, right. You know where it's going to be?
At Medical Associates.
Oh, I thought it would be like a rough draft or something.
All
right. So you think we talked enough about immunizations?
I hope so. No, it's a good topic. It's an important topic.
Right, and we really touched on it. And it's such a major part of what we do. And it's an amazing success story about what we do. So we have to keep that in perspective. And remember, these are successes. I thought we would talk a little bit about something that people might have heard of, which is called burnout. Have you heard of that?
Yes.
So burnout has, it's a real diagnosis these days. It's not just depression or anxiety or exhaustion, but it's a psychologic or psychiatric phenomenon. It was first described by a esteemed psychologic researcher named Christina Maslach. I hope I'm saying that right. But it has three major components. And this comes up a lot in what I do, medicine, healthcare, but it's so apropos to many, many other fields. Almost everybody will listen to this and go, yeah, I understand that. So the three major components of burnout are emotional exhaustion, depersonalization, and a sense of decreased accomplishment. And those kind of, when I'm thinking about those things, they kind of blend into each other as well.
So you mean in the workplace?
Yeah, this is, okay. Burnout is really referring to your occupation, although I think it could apply to someone who feels in other realms of their life.
The list of those three items that you mentioned, I think could happen to anyone, regardless of profession.
Of occupation, yeah.
Right. Yeah. Or even if they're retired.
I'm sorry?
Even if they're retired.
Yeah. And I could think of, maybe someone who's a parent, might feel this way too. Emotionally exhausted, sense of decreased accomplishment. And Robin likes to say that.
Where's your mother?
Yeah, where's your mother? Wait, I'm your mother.
Right, that's me.
Yeah. Yes, and there's a lot of talk about this in the medical profession, but I think it's worth discussing because it does overlap. But you, Robin, I know a lot of people in the teaching profession. I know some people in law enforcement. I think it applies to them. So what does this mean? Emotionally exhausted, depersonalization, and a sense of decreased accomplishment. By the way, they do study it, and it does kind of vary from field to field, and there are a lot of things to consider. Emotional exhaustion. How would you...
So how can you distinguish a diagnosis, right, of a diagnosis, I'm doing that in quotes, of burnout, as opposed to just someone feeling a little down or suffering, some anxiety, or like, when is it severe?
Yeah. Well, there's a lot of, with this diagnosis, is also, we use the word comorbidity. There is a lot of comorbidity. So in other words, someone with burnout might also be suffering from depression, might also have an anxiety disorder, might also have a substance abuse disorder, or they might not. There's criteria we try to utilize when diagnoses are made. But I agree. I think that it's probably I think it would be very difficult to find someone who has burnout enough to the point where maybe they're seeking some help that's also not meeting criteria for another problem, like an anxiety disorder or depression. And why? Why are we burnt out? Were people burnt out when they were farmers? Remember, farming is a very high rate of suicide.
Farming, it's funny that you bring up farming, but farming doesn't end like as an occupation.
Right.
Like it's your life. So it's, sun up, sun down. It's not something that like is over. You don't get off on Christmas if you're a farmer. Know what I mean? You don't. There's no such thing. But in my estimation, growing up in that environment, it was a given. It was just what you did.
Right.
So it's not like you were.
It's possible if it's something where you could like measure your results. Maybe that's good. Maybe that helps diminish your burnout. For example, I don't know.
You bring the crop in, or the milk truck comes every day, or right. That's how that's how you make your living.
Right. But imagine seasons where the crop isn't so good, and
right.
And
one windstorm, a hailstorm, you lose an entire season of apples because there's a hailstorm and all the flowers die. That's your livelihood. I don't know. I find there's like a resilience in people.
Resilience is a word that's used a lot when talking about burnout. So
right, but that could be also misconstrued as like, just get through it. I mean, get over it. What are you feeling so burnt out about?
Right,
just and that's push through.
In the medical world, because it's one of the problems has been when people kind of feel it, it's kind of been placed on the individual. And then that's where resilience. Even though it's a good word, it's also a bad word. Because yes, we should all be resilient. We should all try to persevere and remember what we do and what we like about what we do and what's valuable what we do, rather than let other things kind of bring us down. But it also at the same time kind of puts all the onus on the individual. You are not resilient enough. You need to be more resilient. And I think that's one of the problems with the way the occupations have responded to problems with burnout. What are you going to do differently? And then sometimes some patronizing things. Well, you need to relax more. You need to meditate, take up yoga. Eat better, exercise. All good advice, by the way, but it's still kind of like. It's kind of like trying to treat symptoms and not the disease, so to speak.
Well, classically in America, we take the least vacation as compared to other.
And there's actually growing phenomenon of people taking even less vacation, even though they have it. They don't take it. It's something complicated. Something about this work ethic that you just have. You have to just kind of keep doing it. And Europe, for example, always has had this. Idea of holiday, you took holiday, so that's part of it. So emotional exhaustion, how do you define that? I mean, again, we're all tired, right? We're all tired at the end of the day. What would be different between being exhausted and emotionally exhausted?
How about not ever feeling rested?
Right, never, even after like a good night's sleep, and just it's a little subjective, right? Again, we're all tired at the end of the day. You go home, have dinner, maybe do something relaxing, you go to bed. Emotional exhaustion is when you're just, you got nothing left. You don't even really do that. But emotional exhaustion does lead to depersonalization, and this is common. This is, we see this in so many fields, kind of like the biting the hand that feeds you in the restaurant business. Us versus them. Those people. Those are your customers, by the way. But I think it happens in teaching and in many service fields. I think it happens in things like law enforcement, where the people that the police have to protect kind of become more adversarial rather than a benefactor type model. And yes, it happens in healthcare. We talk a lot about it, kind of like this mismatch between what the patient kind of wants and what they kind of get, and this constant struggle all day long. Appointments are too short; they can't get in a timely fashion. Why can't the doctor call me? He hasn't called me yet. I'm waiting. That kind of constant mismatch can lead to kind of a depersonalization, which is,
not something that you're striving for.
Right. And then finally, the sense of decreased accomplishment. That what are you accomplishing? Was it tangible 50 years ago? Someone, had with the healthcare system. Sometimes it is something tangible. Your diabetes is here. We brought it down to here. Look at that. We've accomplished something. But I think, at least in healthcare, there's so many other ingredients that are thrown in that it's complicating things.
Yeah, we had customers yesterday at the restaurant. They were asking us, they were like, when is your wing night? When do you have your wing night special? And I said, wing night's Wednesdays. But wing night's not like, wing night used to be like a bargain. It was like a night where you could go get wings like for less money than you usually would buy them. But the wings are so exorbitantly priced at this point that there's no such thing. And it's like, well, you can't decrease the cost of the product to have a wing night if you don't make any profit at all. You can't offer that, right? So anyway, it was an interesting conversation with a customer saying that, you want to provide this service, but you can't provide a service for nothing. Know what I mean?
Yeah.
There has to be a benefit to you, or why do it?
Everything's going up, so I suggest they raise their prices at Wing. I think it's okay.
But it made it was just an interesting conversation because the customer brought up the fact that everyone's advertising this now. They're putting it on their menus. They're putting it on, like on posters on the wall. Please understand.
Yeah, right.
We're short-staffed. Please be nice.
Right.
Be understanding. These are the costs that we're up against, even our like napkins and things like everything is so, like everything went up so exorbitantly. Can you please be understanding and be a kind patron, be a kind patient,
Okay, so we'll revisit that after the break.
Thank you, Dr. Eric Stamberg, Robin Baker. Medical Monday. And it's now at the bottom of the hour, and you're with us on Kingston Community Radio, KCR, at AM 920 and 92.5 FM, WGHQ, and online at mykcr.org. 55 degrees on this Monday, September 20th. This last portion of Kingston Community Radio was brought to you by Herzog's. Because the colors and quality of paint you choose matters, Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center, located in the Kingston Plaza, for all of your home building, maintenance, and painting needs. Discover the difference of buying local. Sales ongoing at herzogs.com. We'll be back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
What grows in the forest? Our imagination and our family bonds. The forest is closer than you think. Find a forest near you at discovertheforest.org. Brought to you by the United States Forest Service and the Ad Council.
To some, a baby's babbling doesn't mean much, but it does. Especially if there's no babbling at all. Little to no babbling by 12 months or later is just one of the possible signs of autism in children. Learn more at autismspeaks.org. Brought to you by Autism Speaks and the Ad Council.
Hi, I'm your host, Smokey Cole Bear. Filling in for Smokey, because after 75 years of...
Only you can prevent wildfires.
Turns out there's much more to say. Nearly 90% of wildfires are caused by us humans being careless, dumping our used barbecue coals willy-nilly. Guess the song was wrong. We did start the fire. That's why I respect Mother Nature and her trees, whether coniferous or new car scented. Brought to you by the U.S. Forest Service, your state forester, and the Ad Council.
Hi, this is Shirley Stabe from Kingston, and I support Kingston Community Radio, and so should you.
And we're back, and you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. Thank you for being with us. And a little bit about our weather and forecast for the next couple days. Today is going to be quite a nice day. Sunshine and clouds mixed, high of 76. And some clouds tonight, but a low of 52, nice and cool. And Tuesday, mostly cloudy with a high of 74. And then Tuesday night, we start getting a little bit of showers, 50% chance of showers later in the night with a low of 62. And Wednesday, those showers continue throughout the day, 50% chance of that coming through, and a high of 78. And Wednesday, considerable cloudiness with a 60% chance of rain throughout Wednesday night. And we've got a low about 65 on Wednesday night. And let's get back to the on-air studio. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, locations near you. And as we said, let's get back to the on-air studio.
All right, welcome to the last half hour of this morning's show. We will be here until 9 a.m. If you have any questions or comments about anything germane, I just like to throw that into a conversation.
You just like to say that word.
My favorite Jackson brother, by the way. 331-9255. I know.
You know the number.
I know. I told Dan earlier I had to move a specific medication out of my brain. So.
Now there's room for it. Now there's room for the number. Thank you for that. That was quite a sacrifice.
You're
welcome.
Yeah, thank you. Well, Robin just warned me that this was a big topic and a hard one to talk about. Do you think we've reached too far?
No, but what do you do about this topic medically? Like what can you do for someone who's experiencing these kinds of things in their life or in their profession? What steps do you take to eliminate getting burned out?
Yeah. Good point. And that's sort of why I'm bringing it up. I mean, because the sad truth, and people may not realize this, but when they're kind of having interactions with their healthcare provider that aren't going that well, it might be because they're dealing with burnout, with people within the system that are burned, including the providers. Our estimates are about 50% of us are having, enough of these symptoms to have it be a problem. That's pretty high, isn't it?
Yeah.
And again, it is kind of hard to talk about because it's kind of like, who's going to, we're not asking for people to feel sorry for the doctors.
No.
I mean, and it also is very analogous to so many other people and what they do for a living, and how they're maybe treated in their work environment. So I think that's one lesson, which is to treat each other better. We plead for patience, with us, at the office. We talked about it. We called it etiquette last week.
Right.
Yeah. And another term that comes up is something called moral injury. This is an interesting concept. Moral injury was first described in the context of soldiers who, are supposed to be kind of doing, think of American soldiers, but maybe became a part of a military for very admirable reasons, but then kind of had to take part in things that kind of go contrary to their nature and the effect that has on people. And it's, so, you think about that concept, I'm not entirely comfortable extrapolating it, to what I experienced, for example, because I've never been a soldier, and I think that's a really, pretty, what's the word, a little chutzpah there to kind of like say, yes.
Right. You're not saying that that's what you're feeling, but I think that that's something that people can wrap their mind around. Right. They can have empathy and understand that feeling that a soldier is placed in a situation that they, right.
For example, and it's come up a lot with our nation in Afghanistan, for example, you're given a mission, you do your duty, you do your mission, and guess what? Maybe something like civilians get killed or something like that. That's certainly not why you joined the military or why, so that kind of, internal conflict that can result. And it can have horrible manifestations. It can lead to, post-traumatic stress for military people, lead to anxiety, depression, can lead to substance abuse. So anyway, so people are kind of saying, well, are there elements of that occur in other fields? Certainly, law enforcement, friends of ours who are in teachers, how they have to spend a lot of their time doing things that are not really directly related to working with a student. And in fact, if they said, hey, if I just worked with this is the part of the job I love, but so many other things kind of come into play to distract me from that. And unfortunately, that has happened in medicine, where so much of the job is not necessarily about a direct doctor-patient interaction. Whether it's something we talked about having to reach out to an insurance company to see if something's covered. The complicated nature of just prescribing medications. Whether it's on the formulary, is it the right pharmacy? Is it a 30-day supply? Is it a 90-day supply? Hey, if you do it this way, the copay is a little bit less. Do
you have a coupon?
The coupons. We're required to kind of give data, and this is how we get measured. Kind of this conflicting notion. That if I'm averaged and kind of evaluated on an average, what's that say about the patient right in front of my face, who, by the way, might be not doing as well? Does that person not worth taking care of? That kind of, of course the answer to that is no. The person is worth taking care of, but it's constant conflict of kind of doing things that go contrary to our nature as healthcare, as people that went into medicine.
Right. I mean, doesn't a teacher want a whole classroom full of kids that are compliant and brilliant and, all learn the same way and everybody's getting A's? Wouldn't that be a fun class to teach?
That would be fun. Although
but it's just not reality.
I think, teachers would also say, that they realize everyone in their class is different and they're okay with approaching.
Yeah.
So I don't know if they say expecting everyone to get A's, but they want to be able to teach. That's what they did.
That's what they woke up this morning for.
Right. They don't want to teach to a test, for example. So therefore the school district can then go to Albany and say, look at our numbers, and Albany can say, oh, okay, we'll give you some more money, by the way. By the way, it just makes the rich richer. So that doesn't even work. Anyway,
it's the same concept in medicine and in many, many other fields as well. You have to measure something. And how you measure it is, I don't know, in quotes, is it tangible the way you're measuring it? And then once you get the measurement and you submit the measurement to somebody who says, well, that measurement is worth this much money and this measurement is worth that much money. And at the end of the day, where's the data come from? And can you skew the data so that you make more money?
Yep. And that goes contrary to certainly what I went into medicine for, which was to take care of individuals and make them as healthy as possible and take care of them when they're ill, encourage them to protect themselves against things that might come, this whole realm of having to care about everything else that you just mentioned is really in conflict with the reason I went into this to begin with. So that's sort of where the idea of moral injury comes from. I think, I'm still not entirely comfortable with the analogy to the soldiers, but because I think it goes a little too far. But on the other hand, it kind of is similar,
Can make you understand.
Right. So that's kind of where burnout might be coming from, Anyway, so the reason I wanted to bring it up is to give a little context to why a provider or an office may not be behaving the way they should in the eyes of the patient. You put a little context behind that, And I've been around long enough. This gig has gotten harder.
Well, I mean, and this past year hasn't made anything, easier. You talk to people who work in hospitals or, they're understaffed, they're overworked, they're up against like insurmountable odds, and taking care of people who are like really sick, putting themselves in harm's way. It kind of goes on and on.
Right.
So that whole concept of kind of being nicer to each other and understanding what kind of everybody's up against is really probably a good one.
Right. And right. And it's just like your parents probably said, treat others the way you yourself would want to be treated, treat the doctor's office the way you would like to be treated, or the other way around, Okay.
Yeah.
All right. We do have some time left. I kind of thought we would maybe explore that more, but I think you're right. I think it does kind of, take us a little too far, but these are tough concepts, by the way, and this is all new, and you're going to hear more about it as time goes on, and kind of, maybe, one of the benefits of something like the COVID is it is kind of a reset. Is this a time to kind of reset our values and our culture? A lot of people, why is it hard to find employees, for example? I always say to my medical students and my kids, I say, beware simple explanations, because I think some people are simply saying, I don't want to go back. That was a miserable place to work, and it's no different now. I'm going to look for something else. I don't know. At some point, they're going to need to work, I guess. But the idea that maybe, we need to restructure how people are treated, kind of across the board. You agree with that?
I agree. So I have a question.
Yes,
when
ma'am.
does a person make the decision to go to the ER? Like what is the difference between calling your doctor's office, going to urgent care, or heading to the hospital?
Right.
We get a lot of calls all week long regarding, there's just a lot of confusion for people.
Absolutely. And when I peruse the ER list, I see a lot of things that really should not be in the ER. However, where else are they going to be, right? I mean, it's where every office is overloaded, urgent cares are crowded. So when should you go to the ER? Well, you should go to the ER if you think there's an emergency. Now, that being said, a layperson also doesn't always know if something's an emergency. An emergency could mean like a broken bone or a possible heart attack, but it also could mean that you're just so sick that you really do need care right now, and it can't wait until the morning. And it can't, I have to answer phone calls as part of my job, and they can be a frustrating part of what I do. But if someone's calling and they're saying, "Hey, I don't know what to do with these symptoms," and that's okay. That's an okay reason to call your doctor after hours. And most of the time, we're going to agree with you. We're going to say, "Yeah, you're right. That should go taken care of." So if you think you have an emergent condition, which is defined as something that needs to be addressed either right away or in the very near future, I would say, prior to the following morning. If you're short of breath, that's kind of an emergency. If you're having a lot of pain somewhere, that's kind of an emergency. If you pass out, if you can't, but we're also dealing with a healthcare system that's overloaded and is not really able to meet the needs of the patients. And part of it might be because we're doing all this other stuff. In other words, the answer might be, right in front of our faces. With everything else I kind of have to worry about, if I got rid of that, maybe I would be able to, make room for some more space, slots in my, in my day or whatever. So it kind of comes full circle. So when should you not go to the ER? You should not go to the ER if you don't think you have an emergency present. And some, like, what happens? The psychology illness is complicated. People reach their breaking points at weird and inopportune times. For example, someone, has had a toothache. They've had this toothache for a week or two, maybe even longer. Well, it's all of a sudden getting worse. It would be, in a perfect world, you should, call a dentist and go get it taken care of. Well, it's 3 a.m. now and the pain is worse than ever. And it's a Saturday, and the person maybe tried to call some dentists earlier in the week, and they were unable to, get a slot or whatever. So they go to the ER. They go to the ER for a toothache. Not really the best use of our resources. And, there's not much we could do for them anyway. We could put the patient on antibiotics, maybe, and just recommend like some prescription strength ibuprofen. That's about it. But people do go to the ER for toothaches because they're bad. You ever have a bad toothache?
Yeah, not fun. What about distinguishing between like going to an urgent care as opposed to an ER?
Yeah. In urgent care, I would say the reason you should go to urgent care is if you have an urgent need, which is not an emergency, and your primary care provider is not available. That's how I would define urgent care. So, for example, if, on a Saturday, if you all of a sudden have a fever of 102, but you're not sick enough to justify going to the ER, that would be appropriate to go to urgent care. We talked about it a lot, this idea of convenience and, is convenience really a goal for healthcare? I think it sets up this conflict, that if convenience is one rather than quality, evaluating kind of a long-term relationship, is those are in conflict, because it's kind of a common criticism of primary care doctors, the first appointment was November, or, by the way, it's valid,
Be interesting to hear a patient's, maybe listeners' comments regarding primary care. Like, do you have a primary care doctor? Are you happy with your primary care doctor? There's a lot of doctors leaving our area. Doctors are kind of getting older, retiring. We have a lot of influx of new patients coming into the area who kind of moved here over the past year. They all need doctors. I have people call in the office all day long. They need to establish with a new physician, and our new patient appointments are going out until sometimes March before a doctor can see a brand new patient. And the reactions that you get are like incredulous. They're like, "Are you kidding me? March? That's when I can." I kind of put it like there's kind of like a traffic jam going on right now, where there's just so many lanes, so many physicians, and there's tons and tons of traffic. Right. So tons of patients that all have to, try to be fit in with a doctor that fits them. Yeah. That's a good fit for them, that they feel comfortable with. And these doctors also just people, by the way, and only have so many hours in a work day every week and have so many appointments that they can offer. They can't kick somebody out of their schedule so that you can get in. There's already somebody fit in there. So it's it's
right.
really
it's a kind of a perfect storm, to use another cliche, because you have people coming to our area. You at the same time, you also just kind of have an aging population. You have just the general nature of healthcare, which is to get more complicated, kind of like ectopy, or in the world ever expanding. We do have some kind of baby boomer docs that are in their mid 60s and to varying amounts, kind of retiring. Is there an influx of new providers? The primary care is a challenge, and it's not always easy to find
new blood,
people willing to take it on. Yes. And that's a bigger problem with our healthcare system, which is that we have a very important job, but it's hard to find people that kind of want to do it. You could probably find someone to you can get a colonoscopy in this community if you need one, because we have that. It's going to get worse. Something's got to be done.
Right. So you gotta invest in your residency programs and
yes.
and make primary care a priority, so
right.
that
and primary care has to be more palatable to people, and one of the things that should be more palatable is a better relationship between the patient and the provider. That tension needs to go away.
Yeah. Well, I mean, I don't know how to help people when they call the office and are so dismayed by their inability to get in to be seen sooner. There's nothing I can do. It's very upsetting. Like, you're looking for a doctor. You would like to see a doctor. Yeah. So, but there's no way to get you in right away.
And I know some other doctors that have retired a little bit early, or they leave practice to go for another opportunity because they're,
it's too hard on them.
The emotional exhaustion, depersonalization, and sense of decreased accomplishment. So you see how these things all kind of intertwine.
Your student interns, most of them, it appears that they are going into specializations.
And I always, they're really wonderful young doctors, doctors of the future. They're great young people. They all went into medicine for the right reasons. None of them want to make $1 gazillion. They want to be doctors. But yeah, they're the ones that I've worked with. I don't think I've had one that's chosen primary care. One went into pediatrics. Actually, two did.
Two, yeah.
Pediatrics is always in its own category because it's really just people who love working with children so much. But we do need other doctors. I mean, the guy here last week is going to be a radiologist. We need radiologists. And
right, you can't order an x-ray and have nobody there to read it.
Nope. I can read it, but
But you sometimes want a second opinion.
You need what's called an overread.
Yes.
Because things can get missed.
Yeah, so I guess it comes back to that same topic that understanding. I don't know how you get doctors to go to underserved areas. Are there places where there's just so many doctors that there's just all kinds of availability and.
There's a lot of debate about whether or not there really is a doctor shortage or is there a doctor distribution problem, and these are not new problems. Difficulty going into a rural area or a urban underserved area. There was another time about 15, 20 years ago where I entertained going into Ellenville to start my own practice, and it would have been unfeasible. I wouldn't have been able to do it, because of the. It's just, amazing undervaluing of primary care that's been going on for about 50, 60 years. And there have been attempts since then to make it evened out a little bit, but in many respects the damage has been done. And then when you throw into the fact that the gig has just gotten harder, I read one interesting study that in 1970, there was an article people wrote this article said that they feel that in 1970, a typical primary care doctor saw about 15 patients a day. So, we say, doctors kind of exaggerate a little bit about how many patients are seen per day. In the primary care world, 20 is an okay number. If you get above 20, you're getting into pretty busy. But there's more to do, at the same time. So, figure it out.
Right, more to do in less time.
And more to do in less time. And then when you throw in all these other things, there's coding and buttons you have to click and forms you have to do and phone calls you have to make. It's very challenging.
They don't really make it easy for patients either because everything that people do, they have to have an approval from their doctor or a letter signed by their doctor or can you so they don't make it easy on a patient to get things done either.
No, that's another thing. I'm being cynical now, a little tongue in cheek, but I say one thing about healthcare is we're all miserable. And I don't, again, I'm saying that half jokingly, but the truth is, his patients are not happy, generally. And, so something's wrong, isn't it?
And the goal is to have people be happy providers, happy patients.
There probably
have things go smooth. I kind of always say if someone calls and there's an issue and they're calling us to help them figure it out, to just, we'll take a breath together. Let's take a look. Let's find out what happened. And, we'll figure it out. We'll fix it for you.
I say that about billing problems, just take a deep breath,
Right. You know how upsetting that is to get a bill?
Yes.
You went to the lab and, your doctor wants you to do your lab. So, how fun is that? Don't eat for 8 hours. You make an appointment. You get there. You're waiting. They take your blood, which is not fun. It's not fun to go get your blood taken. And then they process the lab, and a couple days later, you call for your results or whatever, and then you get this exorbitant bill in the mail. So that causes talk about anxiety.
I know, and from my perspective, I always talk about the B12 levels because somehow I was bankrupting Medicare by ordering too many B12 levels. That was the deciding factor that they then had to.
Cut back on the B12.
Tighten the reins on, and it's very, very frustrating. I don't know the answer, except I do know one thing, which is that we got to work together, and it's a two-way street. I'm not a patriarchal doctor. I'm not a kind of do as I say, don't ask questions.
Yeah, let's do that together.
Right. So, but then just because I view it as a partnership. That's a two-way. The opposite doesn't work either, which is doc. I want this, I want that, I want this or that. That doesn't work either. So that has to go away.
Well, we had a good morning.
We did.
Will we see you next Monday, Dan?
No, we're done until October because it was Labor Day.
Doubt. Okay.
It's Labor Day.
Okay. So let's see. What do
we Labor Day Monday.
What do we have next Monday?
It's usually the first 3 Mondays. The first Monday of the month was Labor Day. And then...
the 27th is going to be Dr. Ed Alio. Mm-hmm.
All right, great.
Yep.
He is a audiologist.
Absolutely.
Actually, I'd like him to come in my show.
Yeah.
I want to interview Alio.
Well, why don't you come into his show?
All right. Tell him to give me a call.
Absolutely. No, that's our schedule.
All right.
Dr. Ed Alio will be with Medical Monday for next week.
And we'll be back in 2 weeks?
2 weeks.
All righty.
We have some guests lined up. Big shoe.
The real Dr. Stamberg.
Yeah, I know. The real Dr. Stamberg. All right. We'll see you guys in 2 weeks.
Have a wonderful day.
Bye-bye. I have no idea if anyone's listening.
Thank you, Dr. Eric Stamberg and Robin Baker, for bringing us around for another Medical Monday. And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. Monday, September 20th, 55 degrees right now here in Uptown Kingston. And this last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. And thank you for being with us here at Medical Monday. And every Monday is a Medical Monday. And our talk radio is at its best. Inspired discussions about our communities with the community. And we invite you to keep up with us and be with us at 7 o'clock a.m. tomorrow for a terrific Tuesday. So this is KCR signing off, and we return you to Magic 92.5.